this talk is specialty recognition for emerging dental specialties. So that's you guys. So how do you do it? Well, if you look at the slide, it mentions the AMA. So first of all, is the AMA a credentialing agency? Never was. And is the ADA a credentialing agency? Never was. But the ADA is, the AMA originally had control of medical specialties. And in 1933, there were only 4 medical specialties. And you can see them on the slide. So we published this in the American Board of, American College of Dentists a couple of years ago. So disclosure slide, I have no disclosures to make. I'm a past president of both the ABOM and the AOM. I was previously secretary of the ABDS, but I do not presently have an appointment within the board as I completed my term. I was one of the original founding board members. I am not receiving an honorarium, although my travel fees, expenses, and hotels expenses are being covered by the American Sleep and Breathing Academy. So we're in Arizona. This is in Arizona. You know where that is? How many people have been to the Grand Canyon? How many people have been down the Grand Canyon? A couple, okay. So you may have seen this. This is on the North Rim, and this is a canyon that is about 1.5 miles from the bottom up the North Rim. But you have to walk to get there. And in order for sleep dentistry to get there, you're all going to have to do some walking. You're going to have to move forward. This was actually on a trip that we did with the American Academy of Oral Medicine Grand Canyon expedition, and a number of us are on the boards. That's Suk Ben Wu behind me, and Nelson Rodos over her left shoulder, and then her husband and son, and then a general dentist, True Prosper. And there we are at the bottom of the canyon. So ABDS, AOM, ABOM, you can find all of these on Google. AOM.com is the website for both the AOM and ABOM. The website for ABDS is abds.org. You can always Google that and get into that website and learn more about these academies and boards. So the American Board of Medical Specialties was formed, which took over the process of specialty recognition away from the AMA. So the way that, the AMA had it back then and the way the ADA has had specialty recognition is it makes it difficult for new specialties to become recognized. So this is a slide that's been stolen from Dr. Frank Recker, who is the attorney for the ABDS and also started out as the attorney for the American Board of Implant Dentistry. These are the original specialties recognized by the ADA for dentistry. And as you'll notice that all of them were recognized by 1950, except endo, which was recognized in 1963, and oral and maxillofacial radiology, which was recognized in 1999. So we had, and if some of you want to talk about it later, I can tell you some stories about the process of so-called ADA recognition. How many of you are ADA members? So I'm very active in my local ADA, and organized dentistry is a wonderful thing, and this is part of organized dentistry. But with regard to specialty recognition, this has been an issue, and we'll get into some of the new things that have happened recently. So specialty application denials, this is another Frank Recker slide. So implant dentistry applied in 86, 88, and 93. We in oral medicine applied in 96 and 99. Oral facial pain applied in 2000. And dental anesthesia applied in 94, 97, 99, and 12. And dental anesthesia's application was 100% accepted by Committee G, which is the Specialty Recognition Committee. 100%. But the AMOS, the Organization of Oral Surgeons, put about $100,000 into lobbying the House of Delegates so they would not become a recognized specialty. So there is an inherent conflict of interest, which is technically illegal. Department of Education oversees, supposedly, specialty recognition in areas of education. And what's illegal is that you have the House of Delegates voting, so you have the organization that's a sponsoring organization. The organization which is the supposed recognition is CDEL, Committee for Dental Education and Licensure. And they are supposed to be independent of the ADA, but they're not, because the ADA allows a vote by the House of Delegates, which is an inherent conflict of interest. Because if I'm a specialist, I'm a bigger deal than you are as a non-specialist. So why should I let you cross the same bridge and get the same accommodations that I have? So the ADA discontinued the specialty process for about 2 years independently, and then they instituted changes in the application to make the process more difficult and more expensive, because the House of Delegates does not want new specialties. That's the reality. So more slides from Frank Recker, our attorney. So advertising specialties pre-1980s. I started my private practice after 2 years in the military in 1974. And in Virginia, where I opened my practice, you were not allowed to advertise. And if you had a sign, your sign had to be relatively small. It was basically the laws were set by the state and the state dental board. So credentials and specialties are a professional, intraprofessional issue, and it's what the law allowed in your particular state. So we've had an evolution of the law. So the Virginia State Board of Pharmacy in 1975 ended up with a Supreme Court decision that advertising competitive prices, and this is pharmaceuticals, that pharmacies were entitled to advertise what was truthful. So if they were selling aspirin for $3.75 a bottle versus the rest of the pharmacies that were selling it for $5 a bottle, they were allowed to advertise that. So that opened the door for professional advertising. And then we had Bates versus the State Bar in 1977, and this was in Arizona. Arizona's attorneys were not allowed to advertise. So the decision was that commercial free speech merits First Amendment protection, providing consumers information about the services and products, as long as they are truthful. And the decision was that this would not harm the legal profession. So then we got into state restrictions. Courts began to analyze the power of the state to restrict commercial speech. So the Supreme Court issues were a pivotal decision in the mid-1980s, commercial free speech entitled to protection under First Amendment. And the burden was on the state to justify the restrictions, which is how it is now. Okay, so let's talk about what is a specialist and who cares. There was a recent article in OOO, well now it's quadruple O, that by Desai and Laskin, which they went and they looked at the internet, and they found that they looked at internet advertising of TMD specialists, and they found that the advertised TMD specialists were far from specialists. So a specialist usually infers that one has advanced education and training, usually clinical training, and a certification by a specialty board, a Diplomate. That's a credential. And a clinician who specializes in particular conditions, illnesses, and disease with expertise pertaining to the diagnosis and treatment of those particular conditions, illnesses, and diseases. So somebody earlier on, I think it was yesterday, talked about top-down. So the concern really is what's best for the patients with the concept of medical and dental specialties. So with a specialist, you'd expect to get more experience and better diagnosis, better treatment, although it may be more expensive or less expensive. So oftentimes, for me, as previously non-recognized, actually in the District of Columbia, I'm not a recognized specialist. But oftentimes people have to go to 7 or 8 physicians or dentists before they get to me, because I'm essentially not a recognized specialty, or wasn't until the ABDS. So that essentially makes treatment more expensive. But when they come to me, I'm going to be more expensive than the dentist, the regular dentist, to treat them, probably more expensive than the primary care physician as well. So, but, you know, sometimes the concept of specialist is that specialists are too focused. So it's, I don't know if you've ever heard the expression that oral surgeons have the urge to surge, or surgeons get the urge to surge. And if you send somebody to an endodontist, chances are they're going to do a root canal. And maybe that root canal was necessary, maybe it wasn't, but there's an basic understanding that the endodontists are going to do root canals. So who cares? Well, the patients care, the public does, the generalist does, and other specialists do. And if they know you're on the block, there's more chance that they're going to refer to you. So this is part of the issue. The ADA and the AMA are trade associations. They are not credentialing agencies. So most of the state constitutions have in their bylaws that the dental boards, law boards, medical boards can only utilize credentialing agencies to determine who is a specialist and who isn't a specialist. Accepting the ADA, which 90% of the states do, accepting the ADA's validation of who is a specialist and who isn't, violates those constitutional rules. So what happened with ABDS, and actually it was pretty well financed by the American Board of Implant Dentistry to about $1.5 million, was that we've sued a number of states. Previous to the ABDS, this was implant dentistry. They sued and won in Florida and California. And then recently, we took on the State Board of Texas, and we kicked their butts. Have any of you heard of that suit? A couple people have heard of it. It was the American Board of Dental Specialties versus the Texas State Board of Dentists with allowing ABDS recognized specialties to advertise in the state of Texas. So we won that. Actually, we won that in a summary judgment, and For some reason, the State Board of Texas has challenged that, which means it's appealed. And we assume that we will win the appeal, but, you know, in the legal court of things, no, it ain't over until it's over, as Yogi Berra said. But we're pretty confident we're going to win. And once it's appealed, this was in a Seventh Circuit federal court, it basically becomes the law of the land. Okay, so what about CODA, Committee on Dental Accreditation? So CODA accredits dental schools, dental residency programs, hygiene programs, etc. So CODA gets their wherewithal from the Department of Education. And the reality is that the Department of Education actually asked us, which at that time was the American Board of Oral Medicine and the American Board of Oral Facial Pain, to form a CODA-like organization, and we haven't done that as yet, but we've been asked to do it. And any reputable group can form a board, and once the board is in play for 2 years, that board can become a credentialing agency. Whether or not CODA exists, there can be more than one credentialing agency for residencies. So this is another possible pathway to specialty recognition. What is a specialist? You know, essentially, usually in dentistry, we think of a specialist as someone who has successfully gone through a residency program in an approved residency program, in an approved specialty. So if you've done your 2 years of residency in periodontics, or 3 years in prosthodontics, or 4 years in oral and maxillofacial surgery, and you get through the program, essentially you're a specialist. But with regard to a lot of us have to have hospital credentials, and the hospitals usually demand that you be a diplomat. So I think it's important that people in specialties that are involved with physicians and involved with hospitals attain the diplomat's credential. So what about general dentistry? You know, why can't general dentistry be a specialist? How can you be a specialist if you're a generalist? Well, we have specialists in internal medicine. We have specialists in family medicine. And what that implies is that they've gone through a credentialed residency program and that they've passed the particular diplomat's examinations. So you don't have to be specialized to be a specialist. You have to be educated and prove that you have certain knowledge by taking a psychometric evaluation test. Psychometrics, that's an important term. So internal medicine and family medicine. So emerging dental specialties. So one of the things when we got together, and we got together about 3 years ago, and it was, we were invited by the American Board of Implant Dentistry, and they invited oral medicine, dental anesthesia, and oral facial pain, because we were the emerging dental specialties that were attempting to get recognition through the ADA. And Frank Recker came up with, well, there's got to be a better way than the ADA, and that would be to form a credentialing agency. So we put all our eggs in this basket and formed the American Board of Dental Specialties. But one of the things we set out to do was to be inclusive and to support other emerging dental specialties, such as sleep dentistry. So this is a pathway. And one of the things to do that was we said, well, Rome wasn't built in a day. You got to start from somewhere. And in all specialties, the initial group was grandfathered in. So there's got to be some leeway. You got to start somewhere. And then once you have the process going, you can set it up. And essentially, we set up the concept of either level 1 or a phase 1 specialist or a subspecialty. We're still working on the terms, but that's fungible. So we set it up as ABDS Certified Subspecialty Board is eligible to be certified graduating from a Department of Education approved advanced dental education, and that could be DOE approved, could be your state credentialing agency. It doesn't have to be CODA. So an advanced dental subspecialty, second level, and that's a start-off point. So there are right now with the different credentialing agencies in medicine. For instance, there's the American Board of Physician Specialties, which is rather new. It's about 10, 12 years old. They've set up other models other than a clinical residency at a hospital or a dental school, etc. So like this, actually the startup of that was the Maxi course, Maxi implant course. Any of you guys taken the Maxi implant course? Got a couple. So that is a way of taking continuing dental education and not closing down your practice and doing education that's comparable to clinical residency and having a way of getting the residency credential without actually having to close your practice down for 2 years and move to the city with a residency. And actually, Glenn Clark at UCLA has started up a similar program for oral-facial pain, where you can do the residency essentially over the internet, and then take a couple of 2 weeks in Los Angeles, and then later case presentations, as a way of being qualified to take the diplomat's examination. So there are alternative ways to make this work. So when we won the summary judgment Texas legal decision, we had meetings with the ADA, and we were surprised at how nice they were to us. You know, and basically said, we're tired of dealing with these guys, these delegates, because delegates are politicians. And you know how we all feel about politicians, or some of us. So it shifts the issue of specialty recognition into the individual state boards. So the ADA was seriously worried because the FTC, the Federal Trade Commission, has been breathing down their back because of the way they've done things, which is inherently illegal. So they published ADA Resolution 65. So this basically is an out. You guys can read that. So it's like, we'll push this over to the state boards, and they're stuck with it. So the FTC can get on their backs and leave the ADA alone. The ADA's lawyers are clever. And it's up to the jurisdictions to recognize the emerging state boards and whatnot. It's interesting that I was kind of happy when I saw what the ADA did, because they used, they used oral medicine as an example. And they basically said that it's ethical for us to advertise the truth, that we're a specialist, that we have advanced knowledge, that we're in a particular area, and get the FTC off of the ADA's back. They did a couple of other things. They also struck down the issue of limitation of practice. It used to be that according to the ethics, if you were this specialty or that specialty, like for instance, if you were an endodontist, you were precluded from doing a restoration after you did your endodontics, because that was part of general dentistry. So you'd have to limit your practice to only doing endodontics. So now you can be a specialist, and if you decide you're an endodontist and you want to extract a tooth, well, that's cool. You know, periodontists have been doing this for years. So it just doesn't make sense. So basically, we in the ABDS have changed the rules for emerging specialties, and we're going to talk some more. I'm going to talk with people in the lead on sleep dentistry tomorrow about how do we get this done, and how do we get you guys set up to become specialists. And there's a lot of issues involved. I'll give you a couple of my quotes. Perfection is the enemy of success. You know, sometimes I like the saying, the old redneck saying, get her done. And nothing we do is going to be perfect. But we've got to reach out and make something go. And then the more I know, the more I know how little I know. So I'll end on that. Thank you.